Hello, my name is Anna Neumeier. I am an associate professor of pulmonary and critical care medicine. Clinically, I practice at Denver Health Medical Center, where I'm the associate medical director of our intensive care unit. I am presenting this just-in-time learning and introduction to airway management in the disaster setting. Beginning with disclosures, this session is part of a learning series funded by the Administration for Strategic Preparedness and Response. The content is a product of my work and does not represent a policy of the United States government. The information is designed for your learning, but is not a substitute for medical advice, diagnosis, or treatment. I personally do not have relevant financial interest or relationships to disclose. Let's begin with the learning objectives for this session. By the end of this session, you will be able to differentiate the types of equipment used for airway management, describe the basic approach to rapid sequence intubation in the disaster setting, select an appropriate induction and neuromuscular blocking agent based on side effect profiles, and identify clinical signs of a potentially difficult intubation and create a backup plan. Let's begin by reviewing the definition of airway management, which is the assessment, planning, and a series of medical procedures required to maintain or restore an individual's ventilation, also known as their breathing. This encompasses both basic and advanced management. Basic airway management may be used alone for mild airway obstructions or in combination with advanced airway techniques. This includes non-invasive positional techniques such as a head tilt or chin lift maneuver or a jaw thrust maneuver, both that can alleviate the mild airway obstruction by moving the tongue. Bag valve mask ventilation is a basic life-saving airway management technique. This is fundamental to all of airway management, as it can support and maintain ventilation in a patient who is unable to do so independently. Depending on the clinical scenario, however, these basic maneuvers may not be sufficient to maintain a patient's airway and breathing, in which case advanced management is needed, which involves placing invasive devices to secure the airway. These include oropharyngeal, nasopharyngeal airways, laryngeal mask airways, and endotracheal tube placement, and ultimately, if necessary, cricothyroidotomy. The most important step in airway management is ascertaining when an advanced airway is needed and placing that airway safely. That is what we will be focusing on today. When ascertaining whether a patient needs an advanced airway, it is important to review the indications for intubation and placement of an endotracheal tube, and subsequently the initiation of mechanical ventilation. A helpful way to conceptualize this is using the ABCDE framework. Beginning with A, intubation and placement of an endotracheal tube is indicated for airway protection in the setting of impending airway compromise, for example, due to swelling associated with either chemical injury or inhalational injury, tissue burns, or in the setting of anaphylaxis and angioedema. We also intubate to support a patient's breathing, either for patients suffering from hypoxemic or hypercapnic respiratory failure. For patients with severe circulatory failure and shock, we intubate patients as supporting their respiratory muscles reduces their metabolic demand and minimizes oxygen consumption. This in turn optimizes oxygen delivery, which is important during shock states. Disability references when we intubate patients who have impaired consciousness with inability to protect their airway from aspiration. And E stands for everything else, such as intubating for an operating room or an emergent procedure. The most definitive way to secure the airway is by placement of an endotracheal tube, which is what we will review. However, adjunctive airways and approaches may be needed in certain circumstances. For this talk, we will primarily focus on intubation with an endotracheal tube. Rapid sequence intubation, known as RSI, is an airway management technique that produces immediate unresponsiveness using a sedative or an induction agent, and muscular relaxation using a neuromuscular blocking agent. It is the fastest and most effective way of controlling an emergency airway. However, RSI leads to a cessation of spontaneous ventilation and therefore involves considerable risk if the procedure does not perform intubation or ventilate the patient in a timely manner. Therefore, I recommend having a standard approach to performing RSI, as well as recognizing when an airway may be particularly difficult, such that RSI should either not be attempted or attempted only with a pre-specified backup approach determined. Let's review that standard approach to RSI, which I summarize as the 6 Ps approach. Your first P is your preparation. Ensuring that you have a standard approach to how you prepare for the procedure will guarantee that nothing is missed. You should prepare your room, ensure that you have the appropriate airway equipment, that suction is present, that the monitor is connected with vitals cycling quickly, ideally every 3 minutes. Ensure that you have not only one, but 2 functioning IVs, and that your RSI medications and adjuncts to support the hemodynamics changes that accompany intubation are ready, drawn up, and can be administered quickly. The second P is pre-oxygenation. And as you're preparing for the procedure, you should pre-oxygenate the patient as best as possible, as having a greater hemoglobin oxygen saturation will help prevent hypoxia during apneic periods associated with endotracheal tube placement. Studies have shown that non-invasive ventilation is the most effective way to pre-oxygenate. However, this should only be utilized in patients who do not have this therapy contraindicated. The third P involves positioning in a way to optimize visualization of the vocal cords on direct or video laryngoscopy. This is a picture of positioning using an airway management and a direct laryngoscope. This shows the position you're trying to achieve, which will optimize your visualization of the vocal cords with direct laryngoscopy, either through extension of the neck or elevation of the head slightly with a pillow, known as the sniffing position. The goal is to align the ear with the sternum, which is represented by the turquoise line, to ensure a visualization of the vocal cords with ideally an unobstructed view. The light green line demonstrates your anticipated line of sight. The fourth P involves use of a paralytic, better referred to as a neuromuscular blocking agent, along with an induction agent, as this will improve your laryngoscopic view and first pass success, as well as minimize aspiration risk. This is a table that summarizes the commonly used medications for induction and neuromuscular blockade. When you select your sedation agent for induction, as well as your neuromuscular blocking agent, it is important to remember the dose, potential clinical uses or utilities, and most importantly, the contraindications. The most commonly used induction agent in critically ill patients is etomidate, listed at the top of the table. It is fast-acting, relatively hemodynamically neutral. One very rare caution to consider or side effect is that it can be associated with secondary adrenal insufficiency and worsening shock in the first day after use. Ketamine is an effective alternative and, given its bronchodilatory properties, something useful to consider in patients who are suffering from severe bronchospasm or asthma. When deciding on the neuromuscular blockade, it is important to recognize and remember the contraindications to succinylcholine, which is the depolarizing neuromuscular blocking agent. Because this agent acts by depolarizing the neuromuscular junction, leading to rapid muscle contractions and fasciculations, its use must be avoided in patients who have muscle injury, for example, crush injuries, or those who are suffering rhabdomyolysis, or muscle diseases such as myopathies or toxins that are affecting the muscles and nerves. Additionally, the presence of hyperkalemia is a contraindication to the use of succinylcholine due to the risk of worsening intracellular potassium release associated with the fasciculations. On the other hand, rocuronium, which is a non-depolarizing neuromuscular blocking agent, which does not have these side effects, is often preferential to use. However, it has a longer duration of action, which should be considered. The fifth P relates to confirming placement of the tube. This is done best with direct visualization, but additional confirmation like an end-tidal CO2 monitor, auscultation, are important techniques as well. The final P summarizes the step that must be taken post-intubation, which includes obtaining a chest radiograph, monitoring for and managing hypotension, and then ensuring additional sedation is administered. By thinking through this 6 Ps approach as you plan for an intubation using RSI technique, you will be able to ensure that all steps are adequately followed, as well as identify potential complexities or difficulties to plan for and address ahead of time. Now that we have reviewed indications for intubation and a standardized approach to intubation using RSI, it is important to assess for factors associated with a difficult intubation. Historically, difficult intubation has been defined by the anatomic factors. These include ascertaining whether components of the patient's facial anatomy and composition could lead to difficulty effectively performing an endotracheal intubation via direct laryngoscopy. Similarly, it is important to identify whether patients have factors associated with a difficult bag valve mask ventilation, as if you anticipate you cannot ventilate the patient, then sedation and neuromuscular blockade is too high risk and an alternative approach to securing the airway is necessary. Situational factors may also influence the procedural challenge and can become of particular relevance in a disaster setting. For example, the presence of poor ambient light can influence your visualization. Atypical patient position, which is particularly relevant for emergency medical service providers, can influence the complexity and challenge of the procedure. Having limited equipment or limited time in the setting of a mass casualty incident are also situational factors that must be considered. And finally, physiologic factors should be considered as they will add complexity to the procedure of intubation when they must be managed. Examples of this include obesity. The presence of obesity increases oxygen demand. Similarly, these patients have reduced functional residual capacity. And so upon induction and lying flat in positioning, they are at risk for severe oxygen desaturation. And therefore, one approach may be to alter the position of intubation to help optimize oxygen delivery. Similarly, pregnancy, also associated with a loss of FRC, is a physiologic factor that increases the complexity of intubation. Furthermore, the risk of hypoxemia and damage to the fetus is much higher and must be considered. And finally, the presence of shock or severe hypoxemia are physiologic factors that add complexity to the procedure. Let's discuss anatomic factors associated with a difficult airway and how they can be managed. When assessing for anatomic predictors of a difficult airway, the goal is to identify which patients will have a suboptimal view on direct laryngoscopy. This is often referred to as assessed by a Cormack and Lehane score, and a score of 3 or 4 is associated with a difficult intubation. Factors to look for in physical exam that associate with a higher Cormack and Lehane score or difficult intubations include having a small oral aperture of less than 3 centimeters, which can make it difficult for placing the endotracheal tube via laryngoscopy. Having a short thyromental distance can also make increased difficulty performing direct laryngoscopy. And then finally, having a Mallampati score of 3 or 4 has been shown to be associated with higher Cormack and Lehane scores. If you identify anatomic factors associated with difficult airways, there are techniques to improve the likelihood of success. Both video laryngoscopy and bougie-assisted placement of endotracheal tubes have been shown via randomized control and pragmatic trials to improve first-rate attempts of success with less episodes of severe hypoxemia. Additionally, in situations where the patient has severe airway compromise, such as due to an upper airway tumor or severe edema, rapid sequence intubation may not be appropriate, and instead performing an awake fiber optic intubation would be the safest option. Let's discuss strategies to optimize mask ventilation, as many patients will have anatomic factors that make mask ventilation more difficult. As we discussed previously, this could include having a beard, perhaps being edentulous, or just severe facial diaphoresis. Approaches to improve the efficacy of bag valve mask ventilation include using an oral airway, a nasopharyngeal airway, or using a two-handed technique to optimize the seal and having assistance with another provider to inflate the bag. Also, it's important to have familiarity with laryngeal mask airways. These are supraglottic devices that can be immediately life-saving in a difficult airway situation, as you can place them without direct visualization. LMA is introduced behind the tongue with backward pressure using the index finger, pressing the device against the hard palate until it is completely inserted. Then, using the other hand to push the LMA until some resistance is felt and it can go no further. The collar should then be inflated with a specific volume of air dictated by the size, forming a seal around the glottis to ventilate and oxygenate. Synthesizing all of this, when you plan the procedure of securing a patient's airway, you are not only planning for one approach, but you should instead make a plan A, plan B, and a plan C, anticipating that you could encounter an unanticipated difficulty. During the execution of these techniques, the prioritization should always be maintaining oxygenation and ventilation. If this can be performed safely with bag valve mask ventilation, then future attempts to secure the airway can be pursued. If at any point bag valve mask ventilation cannot be performed, an emergent surgical airway should be obtained. If bag valve mask ventilation is anticipated to never be successful, for example, due to an upper airway compromise, then awake intubation should be performed. By pre-specifying the number of attempts for each technique, you will prevent injury to the airway and you will have your equipment ready for each subsequent approach to ensure you have the greatest chance of success. Here's an example of what that looks like. For example, you have a patient who is critically ill, needs to be intubated. However, you don't identify any anatomic complexities that associate with a difficult airway. Therefore, your initial intubation strategy would include rapid sequence intubation with direct laryngoscopy, perhaps pre-specify maximum 1 attempt, followed by a video laryngoscopy, perhaps 1 attempt, and then if needed, adding a bougie to secure the airway, maximum 1 attempt, such that you're having 3 attempts total. If those were unsuccessful, your pre-specified secondary intubation strategy would be placement of a LMA, or perhaps an intubating LMA. And then plan C would be if you ever reach a point where you can't intubate or can't ventilate, you'll move directly to a cricothyroidotomy. Let's discuss a case to illustrate these points, and then we'll summarize our session. You have a 67-year-old man who presents to the emergency room after a house fire. He was pulled from a collapsed wall and has an open tibial fracture. On exam, he's tachypnic, his respiratory rate is 35, he's hypoxic, he's satting 85% on a 15-liter non-rebreather. His blood pressure is 85/40, his Mallampati is 3, he has a short neck and a beard. Based on his chest radiograph, you diagnose acute inhalational smoke injury and decide to perform an endotracheal intubation. As you approach preparing for the procedure, what anatomic, physiologic, and situational factors should you consider as you plan your approach? So here are the anatomic, situational factors, and physiologic factors that I identified. He has predictors of a difficult intubation with a Mallampati of 3 and a short neck. He also has some predictors of a difficult mask ventilation with a beard and the presence of inhalational injury that could predispose him to upper airway swelling. The situational factors at play are that this is an emergent procedure, and the physiologic factors that are currently present are that he has severe hypoxemia, he's hypotensive, and he's an open fracture and the potential for a crush injury, which puts him at risk for having hyperkalemia. Therefore, these are the approaches you might take. In planning your intubation, you would start with a video laryngoscopy to improve your first attempt success, as well as having a bougie ready. Your plan B might include a laryngeal mask airway, and plan C would always be the cricothyroidotomy. Additionally, to help improve your mask ventilation, have an oral pharyngeal airway ready and 2 people present to perform the BVM if possible to optimize your seal. For pre-oxygenation, adding heated high-flow nasal oxygen could support him, ensuring he's getting IV fluids for volume resuscitation and having norepinephrine present to support the hypotension. Given the presence of hypotension, using etomidate as your induction agent would be best. And then rocuronium for neuromuscular blockade, as the potential presence for hyperkalemia is a contraindication to succinylcholine choline. So this is a visualization and a summary of how you approach rapid sequence intubation along a timeline, thinking of your 6 Ps approach. So between the time of the procedure and 10 minutes prior, you're going to start preparing, getting your equipment, suction monitor, RSI meds, IV, and vasopressors ready. At least 5 minutes prior to the procedure, if you're able to start pre-oxygenation, trying to improve your oxygenation as best as possible. At time 0, you'll induce sedation and then add your paralytic or your neuromuscular blockading agent. While those medications are taking effect, you'll position the patient optimally to enhance your view. Ideally, within 45 seconds, you'll confirm your placement with end-tidal CO2 and auscultation, and then, of course, you'll start your post-intubation management. During this entire process, you are maintaining oxygenation and ventilation with good bag valve mask ventilation, and your approach is influenced by your assessment of the anatomic factors, the situational factors, and the physiologic factors that could predispose the patient to having a difficult airway, and ensuring that you have a plan in place to address that. And with that, I thank you for your attention and for viewing.